Hello, good evening, students. Good evening, doctors. How are you all? Are you able to see me and listen to me clearly? Could you please answer in the comment section? Waiting for your answers. Yeah, hello. Yeah, Mountain Life. Yeah, good evening. Others, I think so. You'll able to listen to me clearly. Fine. Fine. Then that's awesome. Fine. Like then. Good evening, doctors. This is Dr. Sasi for your session on clinical ophthalmology. And in these sessions, we'll be having few perspective, means few clinical perspective about the ophthalmology. Fine. And in this session, mainly it will be of much interactive. Fine. Whatever you think, yeah. I MBBS the lighted lamp. Fine. And like it will be a kind of interactive sessions, and there might be a lag of means like there might be a latency of 5 to 6 seconds. Like once you put your answers in the chat section, I will just there'll be latency of 5 to 10 seconds. Just omit it out, right? And this will be more interactive, and whatever you thinks what will be the answer for that, you can means you are welcome to answer in the comment section, fine. And just get an overview, like whatever we're going to study today, it will be a completely clinical based, fine. It will be completely clinical based on, fine. And the topics we're going to start today, they are this ones, they are this proptosis and the causes for this proptosis. Yeah. Hi, Garin Rija. Hi, hello. Hello from India. Yeah, to the Nigeria. Fine. Yeah, fine. The topics which we're gonna cover, it's about this proptosis. Next one, the causes for the proptosis. This causes might be of different etiology. So we'll dissect this etiology for this proptosis. Fine. This will be our main etiology. Fine. Yeah. Fine. That's it. And at last, we'll just study one more thing about the orbit. Fine. This will be the discussion. Means this will be the overview of today's discussion. Fine. You just be engaged in the comment section. First of all, we'll start this session with this question. Could you please answer me in the comment section after reading the question? Okay, I'm reading along with you. Means you saw a patient who is presenting with the features of unilateral proptosis, right? Unilateral proptosis. Means then means later I will just tell you what is a proptosis. Then it is shown in the image. You'll able to see there is some protruding or the forward displacement of the eyeball. You'll able to appreciate when compared to this other eye. Fine. Next one, on examination, you examine the patient. This was compressible. Means when you were able to compress it, it was compressing. Next, and it increases on bending forward. Means while solving a questions, either it might be an MLE question or it might be any exams in the world. You need to understand and you need to focus on the point which you need to focus. Okay. So in the catch point over in this question, it is what it is. This one known as increase in bending forward, and on further examinations, while you are examining, you're not able to appreciate any thrills or brood, fine. And on MRI it is showing a retroorbital mass with enhancement. What do you think, what is the most likely diagnosis? Could you please answer the comment section the option of the answer for this question? Waiting for your answers. Yeah, guys, come on. Yeah, fine. First let me dissect these answers, fine. If you see this first one, means the answer for the question, I will just tell you in a while. First, if you just solve from the option wise, first if you see, in a case of AV malformations, what you will able to appreciate? In a case of AV malformations, you will able to appreciate this presence of thrill because of this pulsatile. Yeah. Good evening, Narmi Hari. Fine. In a case of AV malformation, you will able to appreciate the presence of thrill, and an auscultation, you will able to find the presence of brood. But both of them, they are absent here. So we'll rule out it's not an AV malformation. Next, in the case of orbital encephalocele, they can be present with proptosis, but they won't be having these typical features that increases on bending. Okay, means there won't be these features which increases on bending. Fine. Next one, orbital varix. This orbital varix means this orbital varix, it presents with this type of proptosis known as intermittent proptosis. Yeah, Narmi here, no, it's not D option, it's option C. Okay, fine. Let me clarify you why it is. Because if you see this orbital varix, it will be showing this type of proptosis known as intermittent proptosis. Fine, intermittent proptosis. And this intermittent proptosis, it will be increasing on bending forward or any and during any Valsalva manner, it will get increased. Fine. Next one, if you see this neurofibromatosis, they can be presented with some other ocular malformations or ocular tumors, but they will rarely present with this intermittent proptosis. Fine. This is why the answer for this question, it is what? It is option C, which is orbital varix. Fine. With this understanding about this question, we'll move on to our first part. Fine. First, we'll get to know what is a proptosis. If you see this, what is this proptosis? This proptosis means there is a forward, means the proptosis definition, it will tell that is the forward displacement of the eyeball. Means it is the forward displacement of this eyeball, which is actually what? Which is actually beyond this. If you're able to appreciate this superior and inferior orbital borders, they are ahead of it. Means it is pushed forward to this superior and inferior orbital margin. So just remember, it is the forward displacement of this eyeball beyond this superior and inferior orbital margins. Fine, orbital margins. And could anyone in the comment section answer me what is the most common cause of unilateral proptosis in children? Someone could try. Fine. For example, last question Narmi had tried. Like this question, someone could have tried. Fine. Means if you get wrong, no worries. Just have a try. Fine. Just remember the most common. Yes, Sundar, you got the last questions correct. Yeah. Fine. If you see the most common cause of unilateral proptosis, it is what? It is divided into. It is most commonly in children. If they ask you, means if they ask you what is the most common cause, you just ask them what is the to whom you are asking. So if the most common cause of unilateral proptosis in children, it is what? It is the cellulitis. In the most common cause of unilateral proptosis is what? It is cellulitis in children. Whereas the most common cause of unilateral proptosis in adults, it is what? It is this condition known as thyroid ophthalmopathy. Right? And if you see this image, you'll be able to appreciate this presence of this bilateral proptosis, means both eyes are involved. And this eyes, you will be able to appreciate this presence of this lid lag. Okay, means presence of this lid retraction. Right? And these typical features. So the most common, and it's adult patient, you will be able to identify it's an adult patient. Fine. So the most common cause of bilateral proptosis in adults, it is what? It is the same, which is the thyroid ophthalmopathy. Right? Thyroid ophthalmopathy. And if you see the next one. The most common cause of bilateral proptosis in the case of children, it is what? In children, if you see, the most common cause, it is what? It is because of these tumors. For example, the tumors might be most commonly it is because of neuroblastoma. Right? And this neuroblastoma, it will produces this type of metastasis, and on producing this type of metastasis, it will come and deposit around this eyes and produces this type of eyes. Could you please identify what is this name of this eyes? Could you please try for this? They will produce this type of eyes, which are known as what? Which are known as raccoon eyes. This presence of this raccoon eyes, which is along with this bilateral proptosis, it will be seen in a case of neuroblastoma, and it is most commonly seen in children, and it is the most common cause of proptosis even. Fine, and there might be some other tumors like chloroma. Okay? Chloroma also they can be associated with bilateral proptosis in children. Fine, just remember these things. With this understanding about proptosis, we know what is the most common cause. Then we'll move on how this answered, means how we able to differentiate this many types of proptosis. Fine. If you see, based on the onset, means there might be acute onset, there might be an intermittent onset, and there might be some features of this proptosis in which we can able to differentiate, or we can just come to a conclusion with a single feature. Fine. If you see this first image, in which in few conditions you will be able to appreciate the presence of acute onset proptosis. When you are able to see this type of, we know the medial wall of orbit, it is made up of this ethmoidal sinus. In medial wall of the orbit, there is a presence of one sinus known as ethmoidal sinuses. Means it contains ethmoidal sinus and it contains ethmoidal air cells. And it contains the ethmoidal air cells. When there is trauma to these air cells, obviously the sinuses they will contain the air. So when there is a trauma to this medial side of this eye, this leads to this release of this air from the sinuses, and this air come and accumulate inside this orbital cavity. We know this orbital cavity will be containing a volume around 30 ml, and this orbital contents they are tightly packed, and this air it is difficult to escape, and this air will keep on accumulating and it will present as an acute proptosis. So in the case of RTA, if he is presenting with the features of acute onset proptosis, you will think of orbital emphysema. Right? You will think of orbital emphysema. Fine. And it will be seen in a case of fracture to the medial wall. Okay, fracture to the medial wall. And means, could you please answer in the comment section, like what is the name of the investigation you will use to see air anywhere? Is waiting for your answers. Just remember, to see air anywhere means we use an investigation known as which is CT. Right? CT it is best for the air, and air it looks hypodense, means black in CT. So it is hypodense on CT. It is hypodense on CT. Just remember. Fine. With this understanding about this acute proptosis, we'll move on to the next one, which is the intermittent proptosis. Means this intermittent proptosis, they will come with a typical history. They will tell this proptosis, they will be increasing on bending forward, bending forward, and sometimes when they're suddenly turning, when they're suddenly moving their head, this is increasing. So turning suddenly, turning the head suddenly, or repeated coughing or sneezing, or during a forceful expiration, means like repeated coughing or like forceful expiration, or sometimes during the Valsalva maneuver, which we used to diagnose some other conditions. During this time, this orbit will protrude out. So during this time, if you see this type of features in a proptosis patients, you will think of this intermittent proptosis. And we saw in the last question, this type of intermittent proptosis means usually it is absent when there is a presence of these features. This there will be a presence of proptosis, and followed by it will become absent, means it will become normal. So this intermittent type will be present in a case of orbital orbital varices. Orbital varices, just remember, or orbital varix, you can just call it as orbital varix. Fine. You just remember. Next one, the nature of this one, nature of the proptosis. There may be this proptosis eye which might be pulsating. Why it is pulsating, I'll just tell you in a while, like why it's pulsating. And this type of pulsatile type of proptosis, if you see a case of pulsatile proptosis, you will suspect might be these two conditions. You can come to a clear cut diagnosis. So this type of pulsating proptosis will be seen in a conditions known as carotid cavernous fistula. Means when there is a fistula formation between a carotid artery and this cavernous sinus. Carotid artery and this cavernous sinus. So when there is this formation of this fistula tract, it leads to this pulsating type of proptosis. And there is also one more condition known as, yeah, good day. Hi, good Harish Raj. Fine. Rishi Raj, sorry. Yeah, this is a type of pulsating proptosis. Next, it is also seen in one more condition known as saccular aneurysm of ophthalmic artery. We know this ophthalmic artery will lead to supply of this, means will supplies this eyeball. And if there is any aneurysm, if there is any presence of this aneurysm or this bulging out over this artery, it will results it will transmit this pulsation. So it leads to this pulsatile proptosis. It leads to this pulsatile proptosis. Just remember these 2 points about how you will able to differentiate this proptosis patients. Fine. And we know like to whom means what is the most common cause and how the answer will be. And now we need to examine the patients. How will you examine or how will you make a conclusion or a diagnosis? Like this might be a case of proptosis. For that you need to ask the history. And on history, what you will ask first, you will ask the name. Fine. You will ask the name and age because we know the most common cause of unilateral proptosis in children. It is what? It is cellulitis. So in children presenting with features of acute inflammation, you will suspect of orbital cellulitis. Fine. And next, the nature of onset. Fine. Nature of onset means how it is. Means there might be because of some trauma, like for example, in a case of acute, there might because of trauma, or there might be some intermittent, or there might be some pulsative. Fine. Then associated signs and symptoms. Like for example, in a case of orbital cellulitis, if there is any inflammation, you know there will be a rubor, means there will be redness, rubor, color, dolor, and tumor. Means there will be redness, there will be a swelling, there will be a temperature. Right? So these are the features will be suggestive. So in a case of cellulitis, it will be presenting with this kind of signs and symptoms. And we know the most common cause of unilateral and bilateral proptosis in adults, it is what? It is the thyroid ophthalmopathy. So in the case of thyroid ophthalmopathy, it's happening because of the thyroid lesions. So this will be having the systemic symptoms. So there will be, we need to check for the presence of systemic symptoms. Fine, just remember. We just asked history and we got this many info. Fine. Now what we need to do? We need to make a diagnosis. And but there is a few things. There is a few things which you will make a some. You need to be always aware about. Means so that you won't means you won't get wrong while you are making your diagnosis. Fine. So you need to differentiate one thing known as proptosis from the pseudoproptosis. Means there is no actual proptosis, but it may look like a proptosis one. Fine. So just remember. So in which conditions? For example, if a child, just let me give you few history. If a newborn or a child or an infant, if the infant is presenting with features of first thing, listen to it carefully. First thing, a large eyeball. Okay, I will tell one more name of it at the end of this thing. Right? There will be a large eyeball and there is a presence of large amount of lacrimation. There is an increased lacrimation along with blepharospasm, and you live and when the baby it's already spasm, but sometimes when you open the baby's eyes, means the baby is having the features of photophobia. Photophobia. Okay, and these are all in this large eyeball. Okay, large eyeball, which is actually what which may look like a bullseye. So it is known as what? Ophthalmos. And this all they are the features of congenital glaucoma. Right? So this congenital glaucoma, this ophthalmos, like a bullseye, like a large eye, this can mimic a proptosis, but you need to know the differentials that it is not an actual proptosis, it is a pseudoproptosis. Next one is the high axial myopia. High axial myopia means, in a case of myopia, the light will fall in front of the retina. Means the light rays will fall in front of the retina. Fine. Whereas why this happens, there are multiple reasons. One of them is this high axial myopia. The normal eyeball axial length will be around 24 millimeter. Fine. But in few cases, in few peoples there might be a small eyeball. Means if there's a small eyeball, you just imagine there's a small eyeball. This ray or this image will be formed begin the retina. So if this image is being formed behind the retina, like in which condition this image is formed behind the retina? Could you please answer? Like oral light, could you please answer in the comment section? Like in which condition you will able to appreciate this light which is being focused behind the retina? Just think. In a condition like hypermetropia. Like remember, in a conditions like hypermetropia, this rays of light, it will fall behind the retina. Whereas normally it will fall on the retina. In a case of myopia, it will fall in front of the retina. And if there is a presence of large eyeball, means if there is a small eyeball, we know it may lead to this hypermetropia. Whereas if there is a presence of this large eyeball, this light rays, it will fall in front of the retina. So it is what it is a myopia. So it is what it is known as high axial myopia. It is known as high axial myopia. Just remember. So this high axial myopia, the person, because of this large eyeball, they can mimic as a proptosis. Okay, this is the catch point over here. Next one is retraction of the upper lid. How this thing will happen? Retraction of this upper lid. Because of some neural palsy, means if this upper lid become retracted, means you will able to appreciate this complete eyeball. Means you will able to see more than the more surface area of the eyeball. So it may mimic, there might be features of proptosis, but it is not actual proptosis. It's just this lid which is being lagged. So to remember this, fine. Just remember this, fine. Next one, if you see, the next one is what it is, the enophthalmos of other eye, or enophthalmos of opposite eye. What this thing is suggestive of? Right? Yeah, mountain life. You are getting it correct. It's small eye. Yeah, fine. Yeah, just keep answering. So that will be a rhythm. Fine. You see, what is this enophthalmos of opposite eye? It is actually what it is, the enophthalmos of opposite eye. For example, if a ma'am calls, like who you will means like there are four members they are sitting. Okay, fine. If you're a first bencher and she will ask someone to answer or like come forward who gonna answer. So first bench students, what they will do is from these four people, one will go front and they will answer for the questions. Whereas when I'll just make this diagram which is being upstored here. Like for example, there's a if you're a first bencher, if ma'am asks like let's answer one, then one he will come and answer. Whereas if you see this last bencher peoples, if you see a last bencher like me, then there will be four people. Okay, when ma'am asks who is willing to answer, you just come forward. So what we'll do is these three people they will go backward. Means these three people go backward. It makes this one to look like he came forward. So this thing, the same principle acts over here. Means if there is any means if other eye, if it gets inside, if there is an enophthalmosis of other eye, means the other eye means that this eye will look like it's like a protruded one. So just remember, so if there is other eyes having enophthalmosis, then this eye will having these features of proptosis. Means so it's actually what it is, a pseudoproptosis. Fine. And we know, like we got the history, and on examinations we able to differentiate between this proptosis and this pseudoproptosis. With this understanding, we need to do some physical examinations and we need to confirm the consistency. For example, we need to do some physical examinations like palpations. You need to palpate and see whether this mass is hard or soft, because in a conditions like for example in a case of cellulitis you will see there is a local rise in temperature. Fine. Then in a case of tumors there will be hard mass, and in a case of conditions like glaucoma you'll able to see there is a woody hard type of eyeballs. Fine. So these things you need to differentiate by palpation. Next one, it is what it is, the auscultations. What is the role of this auscultation? You'll able to see this type of memes which are being circulated before. Like fine, like in which it was written like when you became a doctor by studying online classes. So actually it is not it's not what means what the not medicos things, but it is a medico thing who can understand. Means he's actually putting his stethoscopes in this eye and he's able to listen to this brute which is produced by these AV malformations. Why this is being produced, we'll discuss in a while. Fine. So in the case of AV malformation, we'll do this thing known as auscultation. Means we'll auscultate the sound of the brute. Fine. You just get this thing. So we'll do auscultation in the case of carotid cavernous fistula. Fine. Next one. Because of this proptosis, I told there might be a because of this coming forward, there might be a myopic or hypermetropic changes. So there might be a decrease in visual acuity. So we need to measure the visual acuity level. Means we can measure this visual acuity by using this our favorite Snellen's chart. Right? We know like we'll use the favorite Snellen's chart. If he is uneducated, what type of chart we will use? If he is uneducated, because Snellen's chart will use this alphabets and numericals. Will you please answer me, if he is uneducated, which type of charts, you will use, what is the name of special names given to the charts? Like there are different types of charts. One of them is known as landlord's C rings. Means there will be C. Means there will be a C. You will be able to appreciate the C, right? There will be a C. So this type of C means we'll tell them where this opening is in, and this is known as landlord's C chart. Or we'll just ask them to show the direction of E. So this is known as tumbling E chart. Fine. It is known as tumbling E chart. Fine. So few different charts we'll use to measure this visual acuity. Fine. With this understanding, yeah, we means we got the nature of the handset, we got some history, we did some local examinations and some physical examinations. Now we need to confirm whether there is a presence of proptosis in a with some instruments. For this we'll use this type of instruments which are known as exophthalmometric instruments. For example, the instrument which is being used here, it is known as Hertel's exophthalmometry, right? It is known as Hertel's exophthalmometer. Means what we'll do is, we'll keep on this lateral wall, and there'll be prisms and there'll be a scale. In this prism you'll be able to see the eyeball, means the protrusion of this eyeball, means this prism will be transparent on, so you'll be able to see both markings. You'll be able to see here, and appreciate the both markings and this protrusion of the eye. So you can measure this level of proptosis. So normally the normal level, it will be from 10 to 21 millimeter. If there is any more than increase, if the increase is more than 2 so there is a significance of, or there might be suspicion of proptosis which may arise. Fine. With this understanding, there is also, means just one as a note, you just remember there is one more example method which is easy and simple. Fine, it's like a strip kind of thing. We'll just means we'll just keep like this, and we'll see from the laterally how much it is being protruded. So it is known as Ludis. It is known as Ludis exophthalmometer. Thermometer. Just remember, these are two types of exophthalmometer to assess this level of proptosis. Fine. With this understanding, we'll move on to the next part. Means we confirm there is a proptosis, but now we need to know whether there is a presence of any systemic associations. For example, if the patient is presenting with some systemic features of hyperthyroidism, right? Like for example, tremors, tremors, and weight loss, then we will suspect there might be a history of Graves' disease or hyperthyroidism. So in such cases, we need to do this thyroid function test, and in few conditions, for example, in the case of multiple myeloma, means there are very rare, like in the case of multiple myeloma, we see multiple myeloma. This leads to the accumulation of this light chains of these immunoglobulins around the eyes even. So in such cases, we need to do this serum electrophoresis to make a conclusive diagnosis. Fine. Then we need to do some investigations like X-ray, like what is the level of this proptosis, or we need to do some CT or MR, means if there is any orbital metastasis. For example, in the case of if the child who is presenting with bilateral proptosis, and you suspect it to be a malignancy, and for the soft tissues will do MRI, right? And you can use, for example, if a presence of this pulsatile type of proptosis, it might be because of carotid cavernous fistula. So in such cases, you will do USG Doppler even. Fine. These are the few investigations we'll do. Fine. With this understanding, we came to know like what are the things, how we need to manage a case of proptosis, how we need to starting from taking history, how we need to make a diagnosis, how we can make some differential diagnosis, and how we can investigate this patients of proptosis. Fine. Then we will move on to the conditions which are associated with this proptosis. Fine. And before moving on to the exact conditions, we need to have some differentials. Fine. Like we told, the most common cause of proptosis or unilateral proptosis in children, it is what it is, the orbital cellulitis. And to know what is orbital cellulitis means you need to have a line of demarcations. If you see this line, so if you see this image, you will be able to appreciate this is how this septa of known as orbital septum looks like. And if there is any inflammation in front of this orbital septum, it is known as preseptal cellulitis. And if it crosses this septa, it is known as postseptal or orbital cellulitis. So there is a huge range of differences. Means there is a one septum and there is a huge range of differences. Okay, let me clarify you why it is. Fine. And you will often, very often confuse with this. So to make this differential diagnosis, I kept this preseptal cellulitis first. Fine. If you see a case of preseptal cellulitis, you will be able to appreciate just in front of the septum, and it just the inflammation of this anterior subcutaneous tissue. It is the inflammation. It is the inflammation of subcutaneous tissue which is anterior to this orbital septum. Fine, just a minute. Septum. Okay, this is the only one thing. And the most common organism which is responsible for this preseptal cellulitis, it's a favored organism, which is what? Which is Staph aureus. Because we know most skin and soft tissue infections, it will be caused by this organism, which is what? Which is this Staph aureus. It will be caused by this Staph aureus. Sometimes it can be caused by this Streptococcus species like Pyogenes. Fine, you just remember these things. Then, fine, like these things are okay, but how you will able to differentiate this preseptal cellulitis from this orbital cellulitis? Here's the catch point. You see a case of preseptal cellulitis, there will be just this orbital edema you will able to see. Means edema means there will be no orbital features. There will be just edema of this eyelids and this periorbital skin. Because whatever this thing, whatever in front of this septum, it is getting involved. So there will be edema of this eyelids and periorbital skin. It is a major differentiating feature from this orbital cellulitis. So there will be a, in clinical features, there will be a edema, eyelids and periorbital. And the periorbital region or periorbital skin, you just remember. Fine. These are the things you will able to differentiate from this orbital cellulitis. And remember, just a preseptal. So if it is preseptal, it doesn't went in, so there will be no proptosis. So just remember, for this one word I told this dismissed concept. So just remember, one word means in the case of preseptal cellulitis, the proptosis will be absent. So there will be a absent proptosis. Fine. And we know it is a bacterial infection. So to treat a bacterial infection, what we'll use? We'll use this antibiotic therapy. We'll use this antibiotic therapy. Just remember about preseptal cellulitis, just edema over the lids and edema around this periorbital skin. And it is in front of this orbital septum. Fine. Next one. If you see this next page, could you please means just have this orientation in the mind. Just try to answer within yourself. Like, in the case of preseptal cellulitis, which of the following finding will not be seen? Fine. What do you think of? Just will rule out the options. We know just the orbital septum which is being prevented. So there will be no involvement of even the orbits or even the eyeball. So of course the pupillary reaction will be normal. Fine. Next one. Since there is no involvement of this conjunctiva even, so there will be no features of there will be no feature there will be no features of chemosis. And since there is no involvement of this extraocular muscles, so there will be a normal ocular mobility. Right? So if you rule out, so the answer will be the proptosis. We know there is no involvement of this eye ball and the eye muscles and even the eyeball, so the ocular movements will be normal. Just remember, and there will be no proptosis. Right? With this understanding, we'll move on to this most common cause of unilateral proptosis in children. Which is what? Which is this orbital cellulitis. And you will be able to see same looking, which is trying to cheat. Like if you see from outside, you'll be able to appreciate it is also the same, right? The lid edema and the periorbital skin edema. But when you tell this patient or when you make this patient to open the eyes, here the magic happens. If you're able to appreciate this type of chemosis or this edema over this conjunctiva, these are the features, this chemosis, these are the features of orbital cellulitis. Fine. So just remember, it is the definition of this orbital cellulitis. So to know this definition, it is what is the same acute inflammation of orbit. Means it is this orbit or this acute inflammation of this orbit or soft tissues behind the orbital septum. So this is how the simple one. Like it is behind the orbital septum, so it is what it is, the orbital cellulitis. Tada. Fine. And we know the most common cause. The most common cause of this orbital cellulitis is our same hero, which is the Staph aureus. Staph aureus. And even sometimes here the strep pneumoniae can lead to this type of orbital cellulitis. Fine. And you see what is the mode? How this could happen? In few cases, if there is any penetration of a foreign body, for example, you are going through and there was a wind and you got a small sandy particle which is being impacted into your eye, and this small sand which carried the Staph aureus and impacted in your eye, and this features like foreign body foreign body or like some kind of chisel injuries with infected obviously, or some kind of surgery. For example, you do a surgery known as evisceration, means there is some conditions because of this you removed just means just what is evisceration, let me tell you first. Evisceration, to remember this evisceration you'll be able to see there is a word V. So just make this V ulta, means if you make this V, yeah, puja, Mishra, you are getting it correct. Yeah, puja, yeah. Fine. If you make this V, you'll be able to see the content inside the sclera. You are just scooping out. So you are leaving the sclera. You are leaving the sclera behind. So just remember. So you are just leaving the sclera behind, and you are just scooping out from inside. It is known as evisceration. Whereas in a case of enucleation, like it can be seen in a case of this orbital cellulitis can result from enucleation. In the case of enucleation, means you're just completely emptying this orbit, just removing all structures of this eyeball and the extraocular muscles. It is in which we do in a case of enucleation. Fine. And in a case of chronic dacrocystitis, when we do some surgery like dacrocystorhinostomy, in such cases also they can predispose to orbital cellulitis. Fine. Fine. Yeah, fine. And just as inflammation like other parts, right? What is the significance here? If you see the significance, I told this orbit, it is tightly packed. It's a 30 ml, but it's just tightly packed. Everything here, it is tightly packed. Right? If you're able to appreciate everything here, it is tightly packed. So because of this tightly packed nature, there will be no lymphatic drainage even. So because of this absence of lymphatics, whenever there is a lymph collection or when there is an infection, this lymph unable to drain out, so this infection will remain inside, so there will be a absence of lymphatics play a major role in its pathology. Fine. And I told there is a presence of these contents which are tightly packed. Because of this tightly packaging, the damage will be rapid and they can extend into very fast. They can extend to the next structure very fastly. So there will be a rapid and extensive damage. Fine, just a minute. Next, clinical features. First thing, what we started today, it is what is the proptosis. So, the clinical feature, they'll be presenting with these features of proptosis and all other features of inflammations. Like there will be features of pain, and there will be features of like swelling, and there will be features like this swelling of this conjunctiva, hemosis, and because of this there will be a presence of some kind of redness known as congestion, and there might be I told here it is a postseptal, so it can involve the muscles even. So this can even lead to even diplopia, and sometimes in some severe cases it can lead to even the loss of vision. Fine. So this is how this clinical feature the patient will present with. Fine. On examination, you'll be able to see this same thing. Fine. On examination, what you will see? You will see the same swelling of eye, swelling, proptosis, hemosis, hemosis of the eye, and there will be a decrease in ocular movement. Just remember, decrease in extraocular muscle movements. So these two features, decrease in extraocular muscle movements, proptosis, they will make your diagnosis from preseptal to this septal or orbital cellulitis. Just remember, fine, fine, fine. Yeah, the infections happen. So what? Will give the treatment, it will be scrapped up, right? No, like this can lead to even complications. If you see this eye, you'll able to appreciate this near to this eye there are some spaces, means tightly packed, but behind this there will be a few spaces. So this inflammation over here, they can come and collect as an abscess, or they can erode this bone. erode this bone and can pass into nasal sinus, like sinuses, paranasal sinuses, or you can able to appreciate like there is a bones. This is for the cranium. Okay, so this penetration, they can even penetrate into the brain and they can result in brain abscess, or they can even go into the meninges and cause meningitis. So just remember the complications of this orbital cellulitis, that might be a subperiosteal abscess or brain abscess. It can lead to brain abscess, two abscess it can lead to, or it can lead to meningitis. And this orbital anatomy means it's very quiet, it's very 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 simple, fine. You see this orbit, you're able to appreciate this orbit. This is how this apex of the orbit, and behind this apex of this orbit means there is a sinus known as cavernous sinus. So this dangerous cavernous sinus is there, and it is interconnected on both sides. So this infection which is being spreading here, they can come and easily spread into this sinus, and this even results into this thrombosis. So this can even results into this cavernous sinus thrombosis, right? Thrombosis. An investigation. So we know it's a bacterial etiology. So we will take some swabs and we'll culture it. And to know the extent, we can do means to know the extent on the soft tissue on the bones. We can start with our initial investigations from X-ray. Then we can move on to the CT, and for this excellent soft tissue delineation, we can use even MRI. We can use even the MRI. Just remember, okay, fine. And with this MRI, we will able to differentiate more accurately whether this is a preseptal type of cellulitis or the postseptal or this orbital one. And in treatment, the same antibiotic therapy will use. Initially, we'll start with this simple antibiotic like ampicillin, and later on we'll move on. Means if we found if there is some kind of resistance, if some kind of resistance to this ampicillin, we can try even vancomycin. Okay, vancomycin. So this thing you need to remember, like in a case of preseptal cellulitis, what is the thing? Okay, just I will just summarize in a last slide, in one more slide which is coming here. So you just answer this question in your mind, fine. If the following is the most common source of post-septal orbital cellulitis, so it is our favorite orbital cellulitis, fine. What do you think? What is the most common cause? Means we are asking about this, we are thinking about this most common cause. Means whatever given here, they can lead to these conditions. But what is the most common cause? So if you see, like based on this incidence and the prevalence wise, the most common cause, it will be the paranasal sinusitis. Means if you see sinusitis, it is prevalent in most populations and it is most common. And we know in the medial wall there is a sinus known as this ethmoidal sinuses. And this ethmoidal sinuses will be containing this air cell and they are in close proximity to this orbit. So when there is an inflammation over here, this can pass into this orbital cavity and it can result into this postseptal orbital cellulitis. Just remember, so the most common cause of this orbital cellulitis, it is what? It is the paranasal sinusitis. Whereas this conjunctivitis means if there is just a conjunctivitis, sometimes some rare conditions are immunocompromised, they can come inside. Fine. Next one, in the case of dental abscess, there is a chance which can be having hematogenous blood, there will be less chance, but in medicine it can be and maybe, fine. Next one is the facial cellulitis. Next one is the lacrimal gland abscess, and we know lacrimal gland, it is also in close proximity, it can happen, but it will happen very rarely when compared to this sinusitis, because here and there will be having this more cases of sinusitis. So the most common cause, it is what? It is the paranasal sinusitis. With this, we'll come to understanding about what is a preseptal cellulitis and how we'll be able to differentiate from this orbital cellulitis. So if you see, in both of these conditions, we'll see the presence of eyelid swelling will be seen in a case of both preseptal and orbital cellulitis. And we know in a case of orbital cellulitis, it is more extensive, right? And that means obviously there is inflammation, there might be little pain will be associated. Whereas in the case of orbital cellulitis, you saw this drastic chemosis. So this leads to this huge pain to the patient. So they'll be having this presence of sharp pain or this diffuse pain. Okay. Then and and, and during this extraocular muscle movements, and we know it's just a preseptal cellulitis, it doesn't went inside. So there will be no pain with UOM, whereas here there will be presence of pain with extraocular muscle movement. Next one, you see these features of proptosis. In a case of preorbital, just in front of this septum, so there will be a no proptosis. Here there will be a presence of proptosis. Fine. Whereas there will be no features of diplopia or ophthalmoplegia. There will be no features of vision impairment or chemosis. Whereas all of this will be usually present in a case of orbital cellulitis. So the main differentiating feature it is the chemosis, and then the proptosis. Right? You just have, and there will be a decreased movement in the extraocular movements. Okay, these are the things. I charge the I. Fine. In like since both of them they are inflammatory conditions, of course the leukocytes they may be increased. Fine. With this understanding, we'll move on to the next part. If you see this image, like you'll be getting freaked. Like what's this? Let's actually tell you what is it. Fine. You see this image, you'll be able to see this massively proposed eye. And this actually they will call them as pseudo tumor. Okay, they will it's actually it's a misnomer. It's not a tumor. It's just a inflammatory disease. We didn't know the etiology, so we kept it as it is an idiopathic orbital inflammatory disease. Okay, it's idiopathic orbital inflammatory disease, and it is what it is actually what it is a localized inflammation, which is actually a chronic inflammation, and it is predominantly it is the it is due to the predominant presence of this lymphocytes. Right, there will be a predominant lymphocyte presence here, and just one thing you need to know about this image. This may look this much harsh to you, but it will show spontaneous remission. So it will show this spontaneous remission. And in few cases, it couldn't have some kind of remission. So in such cases, since it's inflammatory conditions, will give so in a management we can try some steroids and some low dose of radiotherapy also we can try. Right? So there is a and just remember it will be associated with unilateral proptosis. You can also see there is a unilateral proptosis and it's like a tumor, but it's actually what it is a pseudo tumor, and it's a chronic inflammation and it will regress spontaneously. Just a minute, fine. So with this understanding, just answer the next question in your mind. Hope so most of you are getting it correct. Which of the following features are seen in adult patients with idiopathic orbital inflammatory disease? Except means they are asking simply which is not a feature. Fine. This type of questions you will expect in a case of Indian scenario exams. Fine. First will come from the beginning. There may be chances of spontaneous remission can occur in some cases. Yeah, sure. There may be remissions of sure, yeah. Then there might be a severe and prolonged inflammation, and it can lead to even frozen orbit. Means there will be no movement of this eye. Yeah, this can be possible, right? And next, if there is no improvement after the steroid, as I told, it's an inflammatory one. Since it's an inflammatory, we can try steroids. Okay, fine. And if steroids doesn't reduce the symptoms, we can try some low dose radiotherapy. So we can try some low dose radiotherapy. So if it doesn't respond to steroids, we can try this. So the next one it is. So the answer will be by ruling out it will be option A. So we need to know what is option A. It is what we know. It's most commonly it is a unilateral one. It is not a bilateral periorbital swelling. It's mostly a unilateral orbital swelling. So this idiopathic orbital inflammatory disease it is a unilateral swelling. Just remember. Okay. With this understanding, we'll move on to the next one. Right? We see this obeys the definition of proptosis means which is coming forward or protruding out from this superior and inferior orbital rims. Fine. So how this typical proptosis looks like, and we know thyroid ophthalmopathy is the most common cause for unilateral and bilateral. It is the most common cause for unilateral and bilateral proptosis in adults. In adults, just remember. Fine. Hey guys, I think so. Most of you are in line. You're getting it things correct. If you have any doubts, just put up in the comment section. Fine. And try to answer more frequently so that we'll be engaged in a much much good manner. Fine. Uh, if you see this image, the first thing you will able to notice is proptosis of this eye. So there will be a proptosis. There will be features of proptosis. Next one, what you will able to see? This lid is being bent back. So this lid is actually need to be here. It bent back, which is known as lid retraction. Lid retraction. And if you see this patient and if you tell him to look down, if normally we peoples, if we tell them to look down, this lid this lid also will come along with that, because if means if you look down like this, then our eye means if we keep on open, it will lead to the exposure keratitis kind of features. So there is no need of it. So this lid will come along with this movement. But whereas in this patient, if you tell them to look down, he will look down. Whereas this eye, it will be this eyelid, it will be lagging begin. So there will be presence of this sign known as lid lag sign. There will be presence of this sign known as lid lag sign. And the most common, we know, you ask the etiology for this thyroid ophthalmopathy. The etiology for this thyroid ophthalmopathy, it is what? It is because of this hyperthyroidism. And you know, it's most commonly hyperthyroidism. But don't forget, it's not only caused by this hyperthyroidism. It may be means like hypothyroidism and euthyroidism can also have this features of thyroid ophthalmopathy, means of this proptosis or this exophthalmos. Fine. So there might be cases of hypothyroidism or euthyroidism also. Right? Customer, like mostly around 90 to 95 cases, 95 percentage of cases, they'll be presenting with these features of hyperthyroidism. Whereas few 5 to 10%, they'll be having this hypothyroidism and euthyroidism. They may have these symptoms. Just remember, okay, don't forget. Fine. And if you see, this most commonly seen in a case of females. We know this hyperthyroidism, which is because of this Graves disease, it is most commonly an autoimmune disease. It is an autoimmune disease, and we know autoimmune disease, they are most commonly seen in females. Fine. Next one, we know there is some kind of HLA association with this Graves disease. The HLA associated and the risk factor for having this presence of this type of HLA known as HLA DR3 and HLA B8. So this type of HLA patients are the patients who are having this type of HLA. They are having this risk factor for developing this thyroid ophthalmopathy. Means they will develop Graves disease and they will develop this thing. Right? Yeah, yeah. What is the big thing? Like there is a thyroid, there is ophthalmopathy, but just think there is some connection missing, right? Like thyroid is here, eye is here. What is the rest part has gone? Where does this rest part go? Right? So to understand this, we need to know the pathogenesis. Why this thing? Why this dude thyroid here is affecting this dude here in the eye? Right? If you see the pathogenesis, we know the most common cause, it is what is the hyperthyroidism, it is the Graves disease. And in the case of Graves disease, we know there is a presence of this antibodies against this thyroid TSH receptor. Means these antibodies, they are being generated against our own TSH receptor. Fine. And this remember, and this TSH receptor, where it is present on our thyroid follicular cells. And thyroid follicular cells. Right? And we know this means most of these autoimmune conditions, they will come and destroy. Whereas here, this is a stimulatory antibody. So this thing, they will come and stimulate this receptor, and it leads to this increase in production or increasing proliferation of the thyroid follicles, and lead to the increase in level of the production of this T3 and T4. So there will be increase in level of T3 and T4. Okay, what's the matter? It's the pathology of Graves disease. Like, what is the big deal? Fine. Here is the catch point. If you see this type of this TSH receptor on this thyroid follicular cells, they will mimic the receptors on the fibroblast. So this fibroblast of orbit or especially of this extraocular muscles, they'll be having this same antigenic feature. So what will happen? These T cells, they will come and attack this fibroblast antigen, and when they come and attack, when there is an inflammation, will tend to protect. How will protect? Will tend to protect. Like whenever there is a flutes, when there is a human loss, how will try to protect? Before the infant death were more. So to prevent the high chances of survival, we were reproducing 9 to 10 childs. The same thing our fibroblast will do. Like since there is some inflammations, T cells are coming and killing, so this fibroblast will get proliferate. So there will be a fibroblast proliferation, right? And along with this fibroblast, this adipocytes also will get proliferate, and there will be a adiposynthesis, right? Or adipogenesis. Just remember, it is a adipogenesis, right? And during this fibroblast excessive proliferations, along with some time, there will be this kind of means the cytoplasm of this fibroblast will be getting deposited by a compound known as glycosaminoglycans. Because of this excessive synthesis, this glycosaminoglycans will be synthesized, and it will come and deposited into this extraocular muscles. When it come and deposit into this extraocular muscles, we know it's a small orbit having this all muscles. Fine, right? It's a pretty 30 ml, right? So if there is come means excess proliferation, the muscle will increase in size. When there is an increase in size, the orbital cavity couldn't accommodate it. So it will push this eyeball outside and leading to these features of proptosis or exophthalmos. So this will be the pathogenesis begin this thyroid ophthalmopathy. Fine. With this understanding, we'll move on to our next one. Yeah. Now the patient means the patient had some features, like had some pathogenesis. Now he is presenting with how he will be having this clinical features and how you can make an exact diagnosis. And for this making some kind of exact diagnosis, we have few signs. Okay, first sign it is known as Darlimpis sign. And in the case of Darlimpis, we saw this thing. I'll just show you once more. Right? We saw there is a retraction. There's a retraction of this upper eyelid, and this will give this type of look. Means so this leads to for providing this type of frightened or this staring kind of look. Fine? This frightened or this staring kind of look. So because of this retraction of upper eyelids, this will be having these features of this staring and frightened appearance. So you can call how dare when you are staring them, you can ask how dare you could stare at me, right? So you can just remember this staring at this frightened appearance will how dare you can stare. Fine, just remember as a mnemonic. Fine. Next one, this is a one sign you will able to see. Next one is this one giraffe sign. One giraffe sign. I don't like when you're able to see a normal eye, when you will look down, this lid will come down. Whereas in the case of thyroid ophthalmopathy, this lid lags. So this type of lid lag, it is known as one giraffe sign. Just remember, we know giraffe is imagine it as a giraffe, right? Imagine it as a giraffe. So if it is a giraffe, means it will be having this long neck, so it can't lag. So it cannot come down. So it will be lagging again. So this type of one giraffe, it is actually what it is. This lid lag sign. It is what it is actually. What it is this lid lag sign on downward gaze. Just remember, fine, and downward gaze. Next one is there are few other signs like Griffith sign. We see this Griffith sign. What is this Griffith sign? Is what it is? There is some kind of difficulty in eversion. Means this is inversion, this is eversion. So because of this retracted lid, you could be unable to, or you will be having some difficulties in eversion of this upper lid. So there is a difficulty in eversion of upper eyelid. Right? Upper eyelid. Next one it is the still vaccine. What is the still vaccine? Means just imagine you are looking at your phone. Still remember for cell. or cell phone. So if you are looking at your phone, you will you will just having this look and you will just keep on scrolling and you won't blink your eyes. So you won't blink your eyes. So this type of infrequent blinking, it is known as which sign? It is known as Stellback sign. Fine? It is known as Stellback sign. Next one, there are few signs you need to remember. Remember ink, I-N-E-K, read it as ink. Means ink, they'll be having this pigment. So if there is an increased pigmentation of eyelids, it is known as what? Jelinek sign. Jelinek signs, it is actually known as Jelinek sign, but you can remember it as ink. Okay, fine. Then next one is known as Enroth sign. If you see this Enroth sign, it is what? It is actually the fullness. It is actually this fullness because of this orbital edema. This because of this orbital edema. This leads to this sign known as Enroth sign, means the patient will feel this fullness because of this orbital edema. Fine. And next one, it is known as the Koch's sign. If you see this Koch's sign, you'll be able to see when you tell the patient to look to this near objects, you need to converge and look, right? But because of this thyroid ophthalmopathy, there will be a difficulty in convergence. So this difficulty in convergence, it is known as what? It is known as Koch's sign. It is known as what? It is known as Koch's sign. Just show. Fine. Next one. Then we have visa. There means visa. What are the risk factors? What is the etiology for it? And what are the clinical features the patient may have? Fine. And based on this, we label it as a classification known as no specs classification. No specs classification. Fine. And based on this, we stage them. When at which stage they belong. And based on them, we manage them. We start to manage them. For example, in case of first one, it's all the initial letters. For example, if you see this first letter, then it refers to its no signs and symptoms. Means there is some exophthalmos, there is some proptosis, but there is no signs and symptoms. Remember, there is no signs and symptoms. Means the signs and symptoms they yet to develop. Fine. Next one, it is the O. Means in this O, you will see there is only presence of signs. Fine. What is the sign? Only signs, whereas no symptoms still. And the signs even they just limited because initially if there is a proptosis of eye, you won't notice it suddenly, right? It will take some time to see the changes, right? So initially what will happen is this lid retraction, the lid will start retracting. So this lid retraction it is the first sign you can think. So this first sign you will able to appreciate it is the lid retraction. So it is limited to lid retraction. Right? It is limited to lid retraction. Next, you will see this presence of signs or symptoms, which will be because of this soft tissue involvement. For example, because of this soft tissue involvement, there is a presence of the soft tissue involvement along with the signs which we mentioned before. And symptoms, which symptoms? Means most commonly it is seen in a case of Graves' disease, and so they will be presenting with these symptoms of tachycardia, fine tremors, and there will be a presence of heat intolerance. So there will be a presence of this systemic symptoms, and along with this, there will be presence of this exposure. There will be presence of this lacrimation and photophobia. Photophobia. Just remember. Right. Next, if you see after the soft tissue involvement, the muscles will means the muscles will start involving, and so here we'll able to appreciate this proptosis in a much clearly. So there will be a proptosis. And next one, it is this involvement or this proper involvement of this extraocular muscles, extraocular muscle involvement. And just remember the case of extraocular muscle involvement. Remember, these extraocular muscles it won't occur randomly. Means there are few muscles who are more susceptible. So to remember this order of involvement of this means order of involvement of this external ocular muscles, you just remember this mnemonic as I am so lucky. I am and so lucky. So the first muscle which is being involved or prone for involvement, it is what it is, this inferior rectus, then it will be involved by this medial rectus, then by this superior rectus, then by the lateral rectus. So the initial muscle which is to be involved is this inferior rectus. Just remember, it is the inferior rectus. Next one, it is this corneal involvement. Why there is a corneal involvement? Because if you see the eye is getting open, so it is, there is a more light which is being exposed here. So because of this more light exposure, it leads to this condition known as exposure keratitis. So this is how this corneal involvement. Next, this thing, because of this massively enlarging eyeball, and we know it's just a 30 ml orbit which is highly packed, but this eye can come forward because it just means it can, there is nothing in outside. Whereas if it start moving and compressing the back structures, it can lead to even vision loss. So if there is an optic nerve involvement, it can lead to this sight loss or this vision loss associated with this optic nerve involvement. Right? Just remember optic nerve involvement. Okay. Some things you need to remember about this nose fix classification. Now we tell means based on this, if he belong to this P or M. So based on this, we'll do the management as initially as possible. Next, we need to know about two concepts. Know about this concept. First thing, it is known as thyrotoxic. What does it state? That means it is thyrotoxic states, means there is an excess of thyroid hormones, means there is an excess of, there is an increased level of, T3 and T4. And we know if there is an increased level of T3, T4, by default, because of this negative feedback, there will be a decrease in TSH. Fine. And this thyrotoxic ophthalmos, it will be seen in a case of Graves' disease. And along with these features of exophthalmos, there will be features suggestive of Graves' disease. Means, as we discussed before, this is just a classification in which one, there is a typical Graves' disease feature, which is known as thyrotoxic exophthalmos, which will be having these features of tachycardia, palpitations, and like tremors and associated exophthalmos. Whereas in case of thyrotropic exophthalmos, remember, it is the thing which we are talking about. For example, in a case of hypothyroidism, or in a case of normal or euthyroidism, there will be just eye features. Okay, there will be just eye features, but there will be no features of thyrotoxic. So it is known as thyrotropic. These are the two things you need to have a differentiations. Means these topics, they are being less discussed, so there are high probability, means you will get confused when you see this terms for the first time. That's why I cut up here. So you just have a orientation. If it's a toxic, means it will be because of this Graves' disease, which is this hyperthyroidism state. Fine. With this understanding, we'll move on to the diagnosis part. We know in diagnosis, we'll do this thyroid function test, and we know here, like in the case of hyperthyroidism, it will be increased T3, T4 along with decreased level of TSH because of this negative feedback, and we can even do some kind of radioiodine absorption. Okay, and then we can do some antibody testing. As we told, this is a autoimmune reactions. Fine. Could you please remember or recall which type of hypersensitive reaction is the Graves' disease? We know. Just remember the type of hypersensitivity reaction. So, seen in a case of Graves' disease. Graves' disease is what it is. Actually, what it is, a type 2 hypersensitivity reaction, and as it is based on a specific receptor, we have given a different classification known as type 5 hypersensitivity reactions only for this receptor specifics like Graves' disease and myasthenia gravis. Fine. Myasthenia gravis. Fine. So for this, we know there is a presence of some kind of antibodies. So for this antibodies, we'll do some kind of antibody detection. For example, in the case of Graves' disease, we'll check for this anti-T TSH receptor antibodies. Anti-TSH receptor antibody. Just remember. Fine. And next, what we will look on? Like for example, if it is a hypothyroidism state, you can check even for anti-TPO antibodies, or you can even check for like sometimes I would check for anti-thyroglobulin antibodies also in the case of hypothyroid or euthyroid state. Whereas in the case of rare thyroid, means like it is mainly because of this hyperthyroidism, which is mainly because of this anti-TSH receptor antibody, which is also known as long-acting thyroid receptor or thyroid stimulating antibody. Just remember, fine, fine. With this, we come to a conclusion. What is the cause for it? Then we need to manage the patients. First, we know it's a management, means it's a multitudinal approach. We need to we need to have we need to control the thyroid. The thyroid if it is getting controlled, then these symptoms will regress within 3 to 5 years. 3 to 5 years by its own. But if not, you need to assess this. You need to do a thing known as periodical clinical workshop, which is thing known as periodical periodical clinical workshop. In this, you need to assess like whether there is a presence of, means on progression. On progression, you need to assess whether there is a presence of any pain, or whether there is any presence of redness, how this swelling is getting increased, or how this swelling because of this proptosis, which is being getting increased or decreased. So how this swelling is being responding, and is there any loss of function? Like what is the loss of function? Here it states like there might be a loss of function in a case of muscle level, there might be a decreased extraocular muscle function, or there might be a decreased vision because of this neural component involvement. So we'll do this periodical clinical workshop, means we'll ask the patient to come for multiple times and we'll assess this progression or this regression of the symptoms. Fine. Next one. Wait, with this we assess how this being progressed. But later on, we need to manage as some conservative management, or if this thing if it's persists for more than 3 to 5 months, or for more than 3 to 5 years, we need to make some intervention so that the patient will be normal. For example, there might be some non-surgical managements you can try. In case of non-surgical, you can think like you can tell, because if there's a lot of swelling, you can tell them to elevate the head, just head elevation. Then you can because of this exposure to this cornea, there might be development of this exposure keratitis. So we can tell them to use some artificial teardrops. So we can tell them to use this artificial teardrops. And we know there is a inflammation which is being going on. So inflammation, we of course we can use our favorite friend, which is what? Which is the steroid. So we can use even steroids as a non-surgical management. So with this, mostly it will subsides. But in few cases, means but in few cases we need to do some urgent intervention. In which cases you will do some urgent like intervention. For example, the proptosis is so much, the patient is going for a sudden vision loss. So in such conditions, we need to do some kind of surgery which is known as orbital decompression. So we need to decompress the orbit, so that the nerves which will get some relief, so that there will be a decreased vision loss. Fine. Or sometimes what will happen is, we know the most common muscle which is being having involvement here is this inferior rectus muscle, and other muscle it can also get involved. But because of this involvement of this other muscles even, what will happen is that, means while healing, means while when returning to normal, it won't return exactly. So there might be a features will be having of diplopia because of this improper alignment of this muscle. So for that, we can go for some extraocular muscle surgeries, just to provide them, or just to correct the vision loss. Correct the vision loss. Just remember. Fine. Just to correct the vision loss. So these are the things we can try. Otherwise, it will regress spontaneously. When you treat this systemic condition, of course, it will get treated. Fine. And we don't need to freak out. Fine. With this understanding about this, thyroid ophthalmopathy, we'll move on to a question. Fine. To try to answer it and we'll try to decode the questions. Why? What is it? Fine. And if you see this question, which of the following are true about this thyroid eye disease except means they are asking which of the following is false. Fine. Yeah. Could you please answer? Or if you could please guess anything? Just there is a few lag. Just I'm just waiting for your answers. I guess. Okay, fine. Let's decode this question. If you see this decoding of this question, you can see first we'll go from the back. Fine. If you see this question, radioactive iodine is used in the treatment of hyperthyroidism. Can worsen this thyroid eye disease. You see this word can, like in medicine, everything is can. Fine. So everything are may or can. Because of this, because of the same properties, this can lead to this worsening of this eye disease. Yeah, this is a true statement. It's absolutely true statement. Next, this is not related with the severity of thyroid dysfunction. Yeah, that's true. Because in a case of in a case of hypothyroidism or euthyroidism also, we'll be able to see this thyroidopathy. So obviously this statement also will become true. And if you see this one, males are affected more than the females. Is it so? Yeah, hello Chavan. Hello, Shab. Yeah. If you see this option, it's just a bit confusing, right? We'll come back. Then smoking is a risk factor for developing thyroid eye disease. Yeah, smoking is one of the risk factor. Like you just add it here. Smoking is one of the risk factor for having this kind of thyroid ophthalmopathy. Fine. And even means on treatment, just I forgot. And on treatment, this for all smoking patients, this thyroid ophthalmopathy they regress somewhat late when compared to a non-smoking patients. Just remember this. Fine. And if you see, we know this Graves' disease is an autoimmune disease. And this autoimmune disease, they are more common in whom? They are more common in females. Okay? They are more common in females. So this is a false statement. So this is a true statement and it is a false statement. So it is more common in females. And it is not more common in males. Just remember these points. Okay? And these are the things you need to remember about thyroid eye disease. Fine? With this understanding, we'll move on to our next part. We saw that's that a doctor who is auscultating the eye, and, this condition which is which is which we are waiting to discuss for this further image. Fine, which is this carotico cavernous fistula, which radiologically we call it as here we'll call it as carotid cavernous fistula. Fine. What is this thing? You see, this is how a cavernous sinus looks like. And in the case of cavernous sinus, if you see, cavernous sinus give passage for this nerves along with this artery, which is very important, which is this internal carotid artery. And normally there is nothing like it's just a little like dude, it's just a passage. It will give a passage, fine. But in some situations, if for example, in a case of some you are doing some surgeries endoscopically, and while doing some cranial surgeries, you accidentally, or you are doing some endonasal surgeries, and you are accidentally traumatized this cavernous sinus, and this ICA is being mixed, means having had been connected with this cavernous sinus and formed the fistula. And this now the fistula will become boom, and this fistula formation lead to this formation of this proptosis, which is a pulsatile proptosis. And an examination and an auscultation, you will be able to see the brood. And let me tell you why this brood is being happening. You see, this is how this ICA looks like, and this is how. Just imagine it is as a cavernous sinus. Normally, there is no connection. Whereas if there is a trauma, if you make some trauma here, and there will be abnormal connection. We know our blood flows in a laminar fashion, and when there is a laminar flow, there will be no sound, means are less sound will be produced. Whereas if you see a case of turbulence, means you will be watching in movies, some Hollywood movies, you will be see when there is a turbulence in the airplanes, you'll be able to see there is a lot of sounds. So same thing, when this when this blood from this artery which is passing through this narrow opening, it will produces this turbulence, and this turbulence will result in the formation of this bruit. Okay, will lead to this formation of this bruit. Fine. So it is basically what it is, an abnormal, it is an abnormal connection between the internal carotid artery and the cavernous sinus. Cavernous sinus. And it is divided into two types. Okay? There might be a high flow fistula or there might be a low flow fistula. And you have to differentiate it. What is the how does a high flow fistula presents with, or what is the risk factor for it, and how a low flow fistula looks like. And high flow fistula, it is usually secondary to a trauma. Means it's usually secondary to trauma. Means any craniofacial injuries, or you did, or like doctors did. It's a doctor's fault during some operations or surgeries you did. So it is what it is known as iatrogenic, or because of iatrogenic reasons. Because of any iatrogenic reasons, this artificial connection which is being created, and this leads to this our favorite part, which is this, which we started our discussion, which is what is this proptosis. And this proptosis will be having this typical feature of this pulsations. We know this artery will pulsate, so this will be having these features of pulsations. So there will be a pulsatile artery, right? And an auscultation, you will be able to see this. See, means you will be able to hear the presence of bruit. There will be presence of bruit. Whereas this low flow fistula, there will be a low blood flow between them, and this happens even in spontaneously. Like why this is being happens when there is a increased pressure, means when in elderly patients when there is a increased blood pressure, sometimes there might be formation of aneurysm, or there might be formation of, there may be rupture of it and lead to this formation of fistula connections, or else during pregnancy this can even develop. So this will be developed, this can then this low flow fistula usually will develop as a spontaneous. So develop spontaneously in elderly elderly patients or pregnancy, who are pregnant women are in pregnancies. Fine, you just pregnancy. Just remember this too. Fine. With this understanding, we know like this is how this types of carotid cavernous fistula. Fine. Yeah, this on examination we found it, and we need to confirm it. How will confirm it? Because we need to do some investigations to confirm it. How we'll do means the investigation we do it is this. What we'll do is we'll do this carotid angiography. We'll do this carotid angiography, or we can use some other methods like CT angio or MR angio even. CT angio or MR angio. And we know means we know if a pregnant woman who is presenting with will avoid giving contrast. So in such cases we'll use MR angio. In case of MR angio, we'll use a principle known as time of flight, in which we won't use contrast. We won't give contrast, but we'll get this angiographic image. So in the case of pregnancies, we'll use this MR angio. And this how this typical features, this you can able to appreciate this presence of this beautiful chemosis. Along means it's not a video, it's a picture. So there will be features of, obviously there will be features of pulsatility. And you can see there is some kind of hyperdense lesions, or hyperdense, which is showing enhancement, means because of this intravenous contrast which is showing this enhancement. Okay, and here you will be able to appreciate this connection. This is how this our carotid artery looks like, and you can able to see there is a fistula which is being connected from this superior ophthalmic vein. Okay, fine. So this is how a carotid cavernous fistula looks like, and you got a case of this, right? Yeah, we diagnosed with using carotid angiography and MR angio or CT angio. And what we need to do now? Will you live like this? No, we cannot live like this. So for this, we'll do some management. Like now we have advanced technology. So what we'll do is we'll go with this angiography. We'll go with this carotid angiography. We'll put our probe like. Yeah, we'll put our probe and we'll go inside the vessels. Like we will go inside the vessels and we'll ablate it. For example, what we'll do is we'll do endovascular. We'll do endovascular ablations, in which we can use some kind of balloons, we can use some kind of balloons, or we can use some kind of coils and make them embolize. And if we make them embolize, then obviously there'll be no fistula and there'll be no proptosis, and the proptosis will reduce sudden, means it will reduce gradually. So just remember, this is how these features of pulsatile proptosis will be seen in a case of carotid cavernous fistula. Fine. With this understanding we'll move on to one more bonus discussion. Fine. Which is not mentioned in your in the slide. So we'll just means just a second. I'll just add an image over here. So then we'll move on to it. Fine. Okay, I didn't got the image. Okay, fine. But without image itself, we'll discuss, and later we'll see the image. Fine. And what we won't discuss, it is something known as blowout fracture. It is known as what? It is known as this thing known as blowout fracture. And if you see this blowout fracture, and this blowout fracture means, first we'll see the etiology. What is the etiology for this blowout fracture? Could anyone answer in the comment section? What is the etiology we'll think of in the case of blowout fracture? If you see this, like, just imagine it is as an eye. Just imagine, fine. It's an eye, and if an eye which is being heated by air, means which is having high circumference than the eyeball, means the larger object which is being hitting the eye, and which is showing this force to this eyeball, and this leads to this increase in remember, it is lead to increase in intraorbital pressure. So if there's an increase in intraorbital pressure, we know it's a highly compacted cell structure, and if there's increase in pressure, it means it cannot, means since we are giving pressure anteriorly, it cannot go somewhere, it need to go behind. So behind it is tough. Whereas if you see, there are two walls which are very thin. The thinnest wall, it is the medial wall. But if you see the medial wall, it will be having this ethmoidal sinuses, or ethmoidal air cells. And these ethmoidal air cells will be arranged in a honeycomb pattern, and this honeycomb pattern will provide a excess strength, and it will provide this excess strength. And this medial wall, it is like second most common to break. Whereas if you see this inferior wall, or this floor of this orbit, means if you see this inferior wall below this orbit, this inferior wall, this is this maxillary cavity, or this maxillary antrum. And this maxillary antrum, which is an empty air filled space, which is a maxillary sinuses, which is empty air. Hello, Bhattu Prakash. Hello. Yeah. Good night, Hasim. Yeah, fine. If you see, this thing, it is just a air filled structure. So if you give this blow here, this air means this blow will come and rupture this floor of this object. So if there is this blow lead to this fracture of, it's actually what it is, the fracture of floor of this orbit. Right? And this floor of this orbit fracture, sometimes it can come along with this muscle, which is this inferior or rectus muscle. So this inferior rectus muscle, sometimes it can get trapped inside it. So it is actually what it is, a large circumferential object which is hitting the ball. Means when you are trying to catch a ball, when you are playing cricket, or sometimes the baseball can come and hit here, or sometimes your friend or your girlfriend we were having some arguments, and she suddenly punch you. So this can lead to this blood fracture. And the most common valve which is being break, it's just the break in the floor of the orbit. So the patient will be presenting with these typical features. So the patient will be having these typical clinical features of this dye features. Just remember this dye. First, they will present you with this dye features. Absolutely, they won't die, but they will present you with this dye features. What are these dye features? You will see, because of this inferior rectus. If you see, because of this blowout, this inferior rectus muscle, it will be trapped. The eyeball will be having this inferior rectus muscle, it will be trapped here. So it will be having this kind of diplopia. So there will be features of diplopia. Next one, I refers to this infraorbital anesthesia. Means this sometimes it can contain this infraorbital nerve. So if there is this entrapment of this infraorbital nerve inside, this leads to these features of infraorbital anesthesia. Infraorbital anesthesia. And we know since the content means since you are given a blow and the content also it's fallen downside, right? And this can lead to this eye which is looking like a small eye, which is known as what? Which is known as inophthalmos. Inophthalmos. And absolutely it's a trauma condition. The patient will be having the features of pain. And here, if there is any floor fracture, it's okay. And there is also containing some presence of air. And if there is any presence of, if there is any medial wall fracture, which is the second most common, there is any medial wall fracture. This leads to this release of air inside this orbital cavity. And the same history repeats. The same thing can happen. It leads to this subcutaneous emphysema. Can lead to this subcutaneous emphysema. And since it's trauma and in conjunctiva, it can present with subconjunctival hemorrhage. It can lead to this subconjunctival hemorrhage. Just remember, fine. And these are the things you need to remember. And on diagnosis, what we will do is we'll take a view known as Waters view. To know this inferior wall or this floor of orbit, we'll use this view known as Waters view. Fine. We'll use this view known as Waters view. I'll show you the normal Waters view. Fine. Then like next session will I'll just show you the radiographic image of an you means like the proper blowout fracture. Fine. Means this is a modified Waters view known as Pierce view means which is actually having this open mouth means which is it is actually a Pierce view. And it is a Pierce view means which is a Waters view with open mouth. Open mouth. And it is known as this Pierce view. And you are able to see this maxillary sinus. And if you're able to appreciate, there is a falling of this inferior rectus muscle. And this will be suggestive of this blowout fracture. This will be suggestive of this blowout fracture. And this sign is known as teardrop sign. Teardrop sign on X-ray. Okay, fine. And this is known as this teardrop sign. And this management it's mostly the conservative. And if there is if it doesn't respond means if it is doesn't respond for your conservative management, then you can do some surgeries and you use some mesh or the flap to to close the opening so that the inferior muscle will no more become trapped. Okay? So the management will be conservative or surgical management. Fine. These are the things you need to remember. Fine. And like these are the things you need to remember about this orbital cavity and about this blowout fracture. Okay. With this we came into a session. Fine. That's it for the day. From my side, fine. Just remember one thing. Like whatever you can do in your life, just have faith in yourself. Because sometimes you may feel low. Means you don't want to continue the same thing, same preparation and same focus. But you need to do it because you already committed to it. So just be committed and have faith. You'll able to do either any exams in the world. You'll able to achieve it with your success. Okay. With the same motivation, we'll meet up in the next sessions. That's it from my end. Thank you. Bye bye. Signing off. Bye bye. If you have any questions, you can just put up in the chat section. I can answer for you. Fine. Just one more note. I think so I'm not able to see any questions in the chat sections. Means I think so. Then most of you are getting the things correct. Then you are in right track. Absolutely, you are correct. Fine. Then just want to highlight you. This is how this blood fracture looks, and you can see this teardrop sign. And it's actually a CT cut section. It's a CT coronal cut section. You will be able to appreciate this teardrop sign. Okay, teardrop sign. Just one. Yeah, fine. Then good night, guys. And have a nice day. Fine. Then tata bye bye. See you.